or interrupt in some fashion. All right, so I think we have a total of 30 minutes. Is that correct?
Yes.
All right, so I'll keep it to hopefully.
Oh, sorry.
I got muted accidentally.
Okay.
Can you hear me now?
Yes.
All right, let's get started. So, we're going to focus on creation and adoption of large language models in healthcare. And I understand there have been, speakers, some of whom are my collaborators on technical matters, and we're going to try to build some intuition around how should you think about this in a healthcare system. I see one MD on the call. I don't know how many others, two MDs. I don't know how many others are medical professionals here, but this talk is geared towards the clinical and medical lens as opposed to computer science. All right, so just to level set, I'm sure the majority of the audience knows about large language models by now. This is just intuition setting. Imagine a world where we had two sentences like this. One of them was, where are we going? The other one was, where are we at? And then if we wanted to calculate this probability of the word going, given these three other previous words, otherwise known as context, that probability would be 0.5. That's kind of, easy cartoon example. Our corpus is only two sentences. Where are we going? Where are we at? Now, if we play this game at a massive level with billions of sentences or trillions of sentences, and instead of having this kind of Bayesian equation, we have a highly complex mathematical form, and we use this mechanism called a transformer, we get this thing that the world has gone a little bit nuts about called a large language model, where the input is text. Inside here is usually a transformer, and then everybody loves to talk about this text output. We're going to focus on this. In general, I'm going to try to talk about things that a computer science presenter would not talk to you about. Now, at what point does a language model become large? That's a matter of debate. Usually above 1 billion parameters, you might say it's large. Okay, so that's the intuition. The key point in our conversation is going to be thinking beyond language. Like, yes, language is powerful and it's great, and ChatGPT is awesome, and there's Claude and Bard and Gemini and so on. But it's all language in the natural language sense. And I think it's more fun to think about any sequence of tokens that has an inductive bias. So yes, everybody likes to talk about text, that's right here, but there's inductive bias in images, in speech, in structured data in the EHR, as we'll talk about in just a second, in ECG signals, EKGs, EEGs, and so on. And you can play this game of unlabeled learning, and the resulting construct on our campus, we like to call it a foundation model. And the citation is right below that. If we're in the text mindset, we end up talking about question answering, sentiment, information extraction tasks. That's usually the scope of jurisdiction. There's a lot of stuff in imaging and object recognition, instruction following, and I'm sure some of you have seen work from OpenAI called Sora, which goes cross-modality. You can go from text to video, for example. The point of this is that there are multiple modalities, about 9 that have been studied in the biomedical space. Actually, no, generally speaking, not just biomedical, music and genome sequences and text and video and so on. The number of assets is probably more than 2,000. This is a slightly old slide. But the fact remains that most models have not seen EHR data. At least no one's willing to publicly acknowledge it, OpenAI or Google or whoever, that their models have seen EHR data in training. And who knows, they may or they may not have. So now, if we look beyond language, and in this case, language is natural language like English that we're using right now, or German, Spanish, Gujarati, what have you. If we look at it from a computer standpoint, any sequence of tokens that comes from a finite symbol set and has an implicit grammar is fine. It's a language. So the structured EMR data comprises a language in that sense of the word. The words in that language are these kinds of codes. It's arrayed over time and has an implicit grammar in the sense that if you see HbA1c above 6 or above 7, you expect to see metformin or insulin or any other diabetes treatment. That is the inductive bias in this. And it manifests if we look over time. That's sort of the key construct. So then there's this massive work happening in the computer science community. What does that have to do with healthcare? So we wrote up our thoughts. This is a bit old now, December 2022, like a month after ChatGPT launched. And we outlined 6 areas where the use of foundation models in healthcare would have value to medicine or healthcare. And we'll talk through a few of them. This one is sort of highlighted because that's where the future is. We're not going to talk about it much other than give you sort of one example towards the end. And we'll focus mostly on the things where we have concrete examples. Now, before we dive in, I want to highlight an article that has the same title as the talk, which this talk is based on, creation and adoption of large language models in medicine. And the crux of the matter is that for us in med schools and health systems, we need to focus on defining and verifying benefits. And that is crucially important. There's a lot of activity in engineering around building models, probably 9,000, maybe even 10,000 different models. I mean, just today, Databricks announced something called DBRX, which is like in their rendering, one of the best performing open source models out there. Outperforms Mistral, outperforms GPT-4, and so on. So building models, as a med school person, I would say not worth engaging in at this minute. Just the DBRX thing took $10 million to build and gazillion amounts of data items. No health system has that much data to build something from scratch and have it generalizable to other places. But I'm sure there's lots of people coming to you and pitching saying, oh, I have this fancy model. I build Mistral, I build this, I build that, I have a derivative, I have a biomed LLM. Can you use it in the health system and your life will be infinitely better? The question is, how do we know? So there are 2 key concerns. One is we need to specify and verify the benefits, and we also need to pay attention to how are we going to deploy in a health IT system. A typical health system is going to run anywhere around 1,000 applications, ranging from the EMR being one of them to other things, backend systems, and so on. And each and every one of those applications is going to want to have AI in it. And as sometimes I joke, we have 500 platforms, each wanting the other 499 to be applications on their platform. Like, that's not going to work. I mean, we'll run out of budget. So we have to think very carefully about what is the benefit we expect and how are we going to deploy it in practice. All right, so back to this structured EMR as a language. Now, if you think about it in that way, this EMR also has documents, which then gives us 2 ways to build language models using the EMR. Way 1 is the usual interpretation of the word language. We have some documents, discharge notes, inpatient admit notes, and so on, and we train a language model on it. And then it lends itself to the tasks of chat and summarization. Or we can say, we're going to look at the entire timeline, because that also has this inductive bias. And that allows us to adopt a slightly different mindset, because in the language sense, we're not going to be asking a question of the nature, how many pages will pass till I see the word Austin? Like, we don't do that in the language modeling. It's not a task they care about. But in medicine, we do care about that. Like, how many months or years will pass before someone has a heart attack? Like, we explicitly want to estimate that. So that lends itself to designing learning objectives that are not inspired from natural language, but are inspired from how the EHR and someone's care unfolds over time. And we can then train a class of models that are inspired from language models, but I like to call them foundation models, because the minute I use the word language, everybody thinks we're talking about documents and English and Spanish and that kind of language. That's not what we're talking about. We're talking about this kind of language, of the sequence of tokens over time. All right, so let's build that. So we're going to call them FEMRs, Foundation Models for Electronic Medical Records. And the intuition is we have this large unlabeled population. We're going to pre-train. In one case, we're going to train to predict the next day's or next encounter's codes. In another case, we're going to try to predict time to a certain code or a certain event. And that's going to give us foundation models. We have 2 of them already built. And then we can adapt them for tasks such as predict who's going to have a heart attack, who's going to get readmitted. And the shared structure of this EHR language allows transfer of these learned patterns. And they're essentially captured in these things called embeddings, the vectors that we learn. And tying it back to the opening, that's this, the numeric representation of the content in a vector space. So we did that. And then doing what I'm telling you to do, which is verifying benefits, we asked if we do such representation learning, and here it uses the word language, probably one of the gravest mistakes we made. This has nothing to do with English and Spanish or German. It's the EHR language. And then we use that to build classifiers for mortality and for readmissions and so on. And you get about 3.5 to 19% improvement. And they decay less as time passes. They port better across subgroups like adult to pediatrics, and better portable across hospitals, like from here to mimic data or to a hospital in Toronto. Then we went to the next thing. The learning objective is time to event. That now, if we train in that manner, obviously it gives us better performance for longer time horizons, but it trains 8 times faster and needs 95% less training data when we're doing these kinds of prediction tasks. And we can do that for about 3,800 events for which there's enough prevalence and sample size to learn. And then we validated it on 15 tasks. That we also released a data set so you can verify the performance gains that we're talking about. And then the last one is going to combine textual content and the structured content. It's going to use an open source model as a base, and like every 2 weeks a new one comes out. It's like, how are we going to ever catch up? And then we'll evaluate for a suite of medical tasks, and this one is not released yet. All of the other ones have these little sort of items here. These are citations in the slide notes, and I'm sure we can get them to you. So all of it, I'm telling you, each of these bullet points is a paper. All right. Now let's look at the other species of models. So we did this review last year, and turns out that the majority of the commercial models have not seen EHR data. They're trained on the internet, but they claim to be medical. It's like, no, that's not medical. That's not a medical record. That's a publication. And then the academic models, there's about 4 of them. The majority have been trained on papers and mimic data. Majority. I think there's 3 that are not trained on just this kind of stuff. There's one from UCSF, I think UCSF BERT. There's one from NYU called NYU-Tron or Neutron, and University of Florida. Those are the 3 that are trained on their own clinical documents. No notion of time, not going over time, just the documents. Other than that, everything else is PubMed and Mimic. So not a pretty sight in terms of where the field is. So then we said, all right, let's look at the publicly available language models, or off the shelf, not public as in available for free and so on, and say, let's verify their claims of how they work. So we're going to now use off-the-shelf LLMs, given that everything else is not really trained on EHR data, so might as well. And the two sort of headline results I would share with you is we're overhyping memorization. And what I mean by that is you'll see headlines as, oh, ChatGPT or GPT passed the medical licensing exam and, passed the bar exam and this and that. That's answering cookie cutter questions. If you put those things to a real life scenario, and this is now old, it's 1 year old, so kind of outdated. But in this particular case, we took about 66 questions that were asked at the bedside and submitted them to GPT 3.5, that's the first bar, and GPT 4, which had just been released back then. When we got their answers, and we already had a reference answer because these were questions that were asked, and we had done some custom data analysis to try to answer those questions using our own data. And then we showed the answer to 12 physicians and said, tell us if the answer agrees with the past known reference answer, it disagrees, or you cannot tell. And great news going from GPT 3.5 to 4. Agreement is up, disagreement is down, unable to assess is down. Great. But the headline result, about half the time, the 12 doctors could not agree what was the case. Was it agreeing, disagreeing, or too confusing? So now that's like having an intern or a med student that's your assistant, but you can't tell half the time whether they're just making stuff up. So verify benefits, and the answer is not so fast. Okay. Now, the other big thing that people talk about is using these models for summarization. All right, so how good is it for medical tasks? So we created about 1,000 instructions from physicians about what would they want an LLM to do if it was running over an EHR. For example, summarize from the EHR the strokes that the patient had and their neurological deficits. That's in the blue box. So that's the prompt. We then retrieve the EHR. At that time, RAG was not fancy or hot. Now it is. And we submit the prompt and this to a language model, which produces an answer. That's the green box. Separately, we ask the clinicians to read the EHR and say, write out the summary manually. Like, what's the right answer here? And then we assessed for about 300 of this, for which we had this 300 right answers. We tried various models like Mistral and GPT. We tried different setups, multi-retrieval settings, and so on. The headline is, even in the best performing case, the error rate is 35%. Not pretty when you're trying to verify benefits. Like you're trying to use this thing and you wanted to summarize the past medical record and you're wrong 35% of the time. Not going to work. So to sort of close out the conversation, this is the same triangle here that we saw before: build, verify, and deploy. Now I've just kept the same colors and laid out as a grid. Each row is a defining and verifying of the benefit. I've shown you examples of fulfilling a prompt that a physician wants, answering a question that came up during medical rounds, or create models that use less training data, that create predictive models or classifiers that use less training data. So I've given you 3 examples. In one case, we built models. These are the 2 models that we built, Climber and Motor. These are using off-the-shelf or commercially available systems, and we're in the process of fine-tuning a public model. All of the things that I'm telling you, I invite you to download the data sets that we're going to soon release. They're not public yet. The URLs are. We got the permission to release. Hopefully, we'll have them out by May. And they all go by the same name. So ehrshot.stanford.edu, inspect.stanford.edu, medalign.stanford.edu. I gave you the example from Medalign for how instruction following works with the clinical data. EHR shot gives you 15 physician labeled outcomes that allow you to then verify that now by using foundation models, are you able to train a classifier with less data, or how is your classifier trained at your site performing in a public benchmark? And inspect is multimodal. It also gives you 5 labeled outcomes, but it also gives you images, notes, and tabular data so that you can test it out in a multimodal setting if you so choose to. And it got a spotlight at NeurIPS dataset benchmark. This one was the best thematic paper at ML4H. Now, where's the world headed? Like, these are the 2 things that I'm most excited about in the past couple of weeks. This is a paper by a company that I am not affiliated with. It's not one of the 3 that I spun out. They build this thing, which is a constellation of language models, which are all orchestrated by this primary model. And then you have a bunch of specialists. Each specialist itself has a whole bunch of internal smaller models. But at the end of the day, they engage in a free-form conversation with a patient, and they tested it with about 1,100 nurses on safety, appropriateness of the response, bedside manner, and things like that, like things that really matter in healthcare. And so I think compound systems, I think, is where the world is headed in order to get the kind of performance we're going to need, or the kind of benefit we're going to need in healthcare. I think focus on accuracy is not going to get us too much. And then the other thing I'll share is multimodal models, where image and prose are paired with each other. So it's kind of hard to see, but in this case, by reading the image, this thing produces that. And while training, it was trained on finding and images together, and is sort of part of the radiologist workflow in an iterative, collaborative way to read an image. And that's from the Yildirim paper. And I will close out with acknowledgments. It's a wonderful team that I have the pleasure to work with. Visiting scholar, visiting faculty as well. Chia Chun from Mayo and Jenna Viens from Michigan, and then the rest of the crew is all Stanford based, and funding from a variety of sources. And then I'll leave with these blogs, which sort of question the conventional wisdom that is being talked about in terms of models in healthcare and so on. So stop here and happy to take questions.
Quick question.
Thank you very great. William, you first.
Are you ready for one? Sorry. I'm Bill Rice. I'm a physician here in Austin, work in clinical informatics. And I wondered about hallucination in language models that we've seen, and if there's a symmetry in other AI models that also produces hallucinations, but that we don't necessarily see because we could see an obvious, a problem with the hallucination in text, because we can all read the text and say that's ridiculous or that doesn't check out. But another black box model, do those models have a symmetric hallucination issue that would be embedded in them as well?
Yep. So that's the short answer. If you want to try them out, there's a bunch of image generators on the web, and you can give it some prose, some commands, and say,